Okay.
So this is Dr. Rahimian. I'm an MD and PH neurologist. Today I'm speaking about an overview of episodic neurologic disorders. We will discuss in the definition and etiology, classifications, precipitating factors, and a brief overview of some subtypes which are more common, including diagnostic workup, differential diagnosis, and also treatment options. I want to start with an interesting case that I personally have seen and had experience with it. It was a 29-year-old Hispanic male. He presented to the emergency department with sudden onset paralysis. The previous night, he had attended a party in one of his friends' house, and the patient had gone to bed at 12 p.m. with no weakness and awoke at midnight, and he was unable to move his lower or upper extremities. He denied any pain or paresthesia, and also his past medical history was negative, except for another weakness episode, which happened a few months ago and had been less severe and self-resolved. That episode was also after attending a party. During the examinations, the vital signs were normal, except a sinus tachycardia with a heart rate of 120. He had no respiratory or swallowing difficulties. He was mildly obese and had cool and dry skin. On neurologic examination, he had bilateral symmetric weakness in both distal and proximal muscles, and his force was 2 to 3 out of 5, and he had a generalized areflexia. Other neurological and general physical examinations were normal. Well, since he had an acute weakness, there are some differential diagnoses. We should consider stroke, Guillain-Barré syndrome, post-seizure paralysis, Myotonia gravis, or even cataplexia, or some inflammatory causes like polymyositis or dermatomyositis. There are some infectious causes like polio, diphtheria, or botulism, and some metabolic like porphyria. Routine chemistry, liver enzymes, and complete blood count were normal except for a potassium level of 1.6, which is very low. His labs also showed he had a hyperthyroidism. 2 hours after initiation of intravenous venous potassium replacement, the patient's neurologic symptoms completely resolved. The diagnosis of periodic hypokalemic paralysis was made for him, and he was advised to avoid eating the bulks of calories in parties, and also he was started acetazolamide. Well, channelopathies are a group of disorders that result from a number of genetic or acquired defects in ion channels, which are located on cell membranes. They can be defects in sodium, potassium, or even calcium channels in the brain, on the muscles, or even the heart. They present with episodic manifestations, which are cardiac, CNS, or muscle. And the patients are usually normal between the attacks. The symptoms range from rare muscle disorders or movement disorders to more common forms of epilepsy and migraine headaches, which are also considered some kind of channelopathies. The changes in the channels are sometimes abnormal gain of function, like myotonia and epilepsy, or abnormal loss of function, such as weakness or numbness, like the case I just presented. Although on surface these disorders appear quite different, there are strikingly similarities across all these diseases. They all have episodic nature, same precipitating factors, and the same natural history which I explained more, and apparent hormonal influences and therapeutic responses are somehow same between these disorders. The natural history of these disorders is similar because they often present in childhood, they worse through adolescence and young adult life, and improve and sometimes completely resolve in middle or late adult life. Channelopathies can be divided in two main categories, inherited or acquired. Inherited categories can cause neurological symptoms or cardiac symptoms, which are arrhythmic, and we will not discuss these subtypes today. And also there are acquired forms like myasthenia gravis, Lambert-Eaton myasthenic syndrome, paraneoplastic cerebellar degeneration, or limbic encephalitis, which are all caused by autoimmune antibodies. There is also a category of toxin-induced, which are pretty rare, as which are manifested as episodic symptoms. Classification of neurological channelopathies according to the channel type which is involved in the disease. If the sodium channel is involved, we have hypokalemic periodic paralysis, hyperkalemic periodic paralysis, paramyotonia congenita, and potassium aggravated myotonia. Chloride channel myotonia congenita and two symptoms, Thompson's or Becker's, and calcium channels hypokalemic periodic paralysis, episodic ataxia type 2, malignant hypothermia, familial hemiplegic migraine, and childhood absence epilepsy. If the involved channel is a potassium channel, we have Anderson syndrome, episodic ataxia type 1, hypokalemic periodic paralysis, benign familial neonatal convulsions, hyperkalemic periodic paralysis, and malignant hyperthermia. If the glycine receptor is involved, we have hyperplexia, and acetylcholine receptor is involved in the autosomal dominant frontal lobe epilepsy, and GABA receptor is involved in the juvenile myoclonic epilepsy. I will describe some of these diseases, not all of them. As you see, we have sodium channels, potassium channels, and calcium channels, which are involved in these disorders, as I explained in the previous slide. One of the important types of episodic disorder is myotonia congenita. It usually presents in infancy and early childhood. There is a stiffness in muscles and decreased relaxation. The stiffness decreases with activity and it worsens by cold. So these factors may cause the episodic symptoms of this disorder. And the children have muscle hypertrophy, and treatment is with mexilotine or phenytoin if severe. The other one, which is important, is malignant hyperthermia. It is an autosomal dominant disorder. It presents with rigidity, weakness, myalgia, and rhabdomyolysis, sympathetic overactivity, and in the laboratory examination, we might see lactic acidosis, hyperkalemia, and increased creatine phosphokinase. The triggers are some generalized anesthetic agents and also exercise and some neuroleptic or antipsychotic drugs. Treatment is with cooling, hydration, and also dantrolene is an important treatment. Another disorder is a familial hemiplegic migraine. It is autosomal dominant and it involves the calcium channels. For the diagnosis, we need at least 2 attacks of migraine with aura, and the aura must include reversible motor deficits. The patient presents with weakness and it should be reversible. So after the episode has passed, the patient will be normal. And there is a positive family history since it is an autosomal dominant disorder. And treatment, again, interestingly, is with acetazolamide and verapamil, which affect the ion channels. There is also two types of episodic ataxia. These patients present with ataxia attacks that are intermittent, and between the attacks, the patient is completely normal. Both of them are autosomal dominant. Age of onset is for the episodic ataxia type 1 is second decade, and they present with ataxia, dizziness without vertigo, and visual blurring, and they do not have any nystagmus. There are some exacerbating factors for episodic ataxia type 1, which is abrupt postural change, emotion, startle, and vestibular symptoms. This is interesting that emotional changes might trigger these symptoms, so they might be misdiagnosed as psychological ataxias. The duration of attacks are brief and last only for a few minutes. Additional features are symptoms like neuromyotonia, which is a continuous spontaneous muscle fiber activity, or myokemia. They occur, and between episodes of ataxia, some patients have hyperhidrosis and seizures, but most of them are normal. The treatment is with phenytoin, carbamazepine, but not acetazolamide. Another type is episodic ataxia type 2, which is autosomal dominant. This one presents earlier, which in early childhood or teens. They present with ataxia, truncal instability, which may persist between attacks, dysarthria or nystagmus. So the symptoms are more prominent than type 1. And it is associated with vertigo, nausea, vomiting, and headache. Weakness may occur during spells and can precede onset of episodic ataxia. This type also can be triggered by physical or emotional stress. Attacks often last 30 minutes to even more than 24 hours. Additional features include downbeating gaze evoked nystagmus. It means that when the patient looks downward, they start to have nystagmus in the eyes, which is downbeating, in all directions between episodes, and impaired vestibulo-ocular reflex, optokinetic nystagmus, and smooth pursuits. Some patients develop progressive cerebellar atrophy, and the treatment of this type is acetazolamide. So it's important to differentiate between these two types because the treatments are different. Two other disorders are hyperkalamic periodic paralysis and also hypokalamic periodic paralysis. The inheritance is autosomal dominant in both of them. Hyperkalamic subtype usually presents in the first decade of life. Attacks increase in frequency and severity until age 50 when they decline. There are some exacerbating factors like resting after exercise. This is an interesting symptom and trigger. Cold, potassium loading, pregnancy, glucocorticoid use, stress, ethanol fasting, for example, every morning before breakfast, they might have attacks. The distribution of weakness usually is proximal and symmetric, and they have flaccid paralysis, and occasionally distal and asymmetric in exercised muscles. Duration of attack is maybe minutes to hours, but more and is more frequent than the hypokalamic types. So the patients have more frequent attacks. The severity of attacks are mild to moderate and can be focal. They may be associated with paresthesias before paralysis. Deep tendon reflexes are abnormally diminished or absent during the period of paralysis, and many older patients develop a chronic progressive myopathy with prominent weakness that may be unrecognized. The symptoms are relieved by carbohydrate intake or mild exercise, and serum potassium level is usually high but can be normal during attacks. Some patients might have myotonic discharges in the electromyogram, and acute treatment is inhaled salbutamol, which decreases the potassium. In the hypokalemic subtype, which was the case that I discussed first in the presentation, they usually present in the second decade of life. They have, and usually the exacerbating factor is resting after exercise, cold or carbohydrate loading, and even menstruation. So hormonal changes might affect this disorder too. The distribution is of this weakness is paraparesy or tetraparesy and sparing cardiac, respiratory, and facial musculature. The duration is hours to days. The severity is moderate to severe. And the additional features include a myopathic form, which results in a progressive fixed weakness, predominantly in the lower limbs, which occur about in 25% of patients. So some mutations predispose to patients to rhabdomyolysis. Serum potassium is usually low. It is rarely normal. There are no changes in the EMG, and the treatment is correction of potassium level. For the channelopathies, there are some common precipitating factors such as stress, sleep deprivation, certain dietary factors like manipulation of dietary potassium, caffeine, alcohol, high caloric foods, and also hormonal changes. There are some treatment options. Most of channelopathies respond to carbonic anhydrase inhibitors like acetazolamide, which decrease attack frequency for many patients, like those who have periodic paralysis, episodic ataxia, and also migraines. Mexiletine is another drug that locks fast sodium channels that can be effective in many patients, and other anticonvulsants that affect sodium or potassium or calcium channels are also effective in treatment of patients with seizures, paroxysmal dyskinesias, and myotonia. An important differential diagnosis is psychogenic movement disorders. The psychogenic movement disorders are characterized by unwanted movements such as spasms, shaking, or jerk involving any part of the face, trunk, or limbs. In addition, some patients may have bizarre gait or difficulties with their balance that are caused by underlying stress or some psychological conditions. Some patients may have their speech or voice affected, and these are relatively common in patients with psychogenic movement disorders. So this might be a clue to diagnosis. And patients might experience stuttering, speech arrest, lower speech volume, hypophonia, or even a foreign accent. A variety of blood imaging and other tests are usually normal and do not reveal any physical or organic cause that could explain these motor abnormalities. Most psychogenic movement disorders are considered involuntary, so the patient is not doing them on purpose, and we should keep this in mind. Psychogenic movement disorders can mimic organic movement disorders such as tremors, dystonia, myoclonus, Parkinsonism, tics, and paroxysmal dyskinesias. Clues to the diagnosis are suggestibility. So the patient might have an attack if we suggest to him that in this condition you might have this disease, or even if you do this, you can improve. And we see that they improve. Response to placebo treatments, history of psychogenic disorders, and if we have non-consistent neurological examination during attacks. So if the patient has a very sudden onset of weakness, but has preserved reflexes, for example, or other non-consistent neurologic examinations. History of acute stressors is important, and also the term labella indifference, which is a French term and means beautiful ignorance. So the patient, it seems for the patients that the symptoms, which are severe and even disabling, are not so important as they should be. They have a paradoxical absence of psychological distress. and to the symptoms or health condition, and they are not as worried as we expect them to be. An example of the functional or psychological paroxysmal disorders is paroxysmal dyskinesia. They have episodic movement disorders, abnormal movements that are presenting just during the attacks, and in between the patient is normal. By dyskinesia, we mean a distortion or difficulty performing a voluntary movement. They commonly present as an isolated dystonia, which is stiffness of the part of the body. And in one study, approximately 70% of patients with this disorder had a combination of different movements. So they have, for example, tremor, dystonia, Parkinsonism disorders, and which were combined to each other. A weakness, marked variability in duration and frequency of dyskinesias is very important. And also there is an identifiable trigger. If we take the history of the patient very carefully, we might find an identifiable trigger, which is not typical for organic paroxysmal dyskinesias. Although, as I mentioned before, some of them can be triggered by an identifiable trigger, such as stressor or even a loud voice or a startle might start the organic disorders. But in 50% of patients in that study, they found an identifiable trigger. So, and these are my references, and I will be happy if you have any questions to answer. And thank you for listening.